Hello everyone, I am Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be discussing some of the important clinical based questions in the respiratory system and as well as the critical care illness. So I'll be discussing 10 important multiple choice questions, right, which are very much expected questions in the SS exams. Okay, so let us start with the questions. So the first question is, we have a 25-year-old man. He is brought to the emergency department by ambulance after his family found him unresponsive at the home. He has history of intravenous drug abuse and HIV with medical non-compliance, and his last CD4 count was less than 200 per microliter. On initial evaluation, his blood pressure is 120 by 75 millimeters of mercury, and heart rate is 105 beats per minute, and respiratory rate is 8 breaths per minute, and oxygen saturation is around 83% and the temperature of 36 degrees centigrade. A blood gas on room air reveals the pH of 7.16 and partial pressure of the carbon dioxide 70 millimeters of mercury and partial pressure of the oxygen 55 millimeters of mercury. Which of the following is most likely diagnosis? Right? Which of the following is the most likely diagnosis? The options are asthma, narcotic overdose, pneumococcal pneumonia, pneumocystis pneumonia, pulmonary embolism. Right? So first I'll tell you the answer and then I'll try to rule out the other options as well. So very important point here is respiratory rate of 8 per minute, and the individual is having intravenous drug abuse. That itself tells us that the individual is under the effect of the narcotic overdose, because it is the narcotics which will reduce the respiratory rate. They will cause respiratory center depression. Whereas you take other options like asthma, pneumococcal pneumonia, pneumocystis pneumonia and pulmonary embolism. In all other options, the respiratory rate is increased. There will be tachypnea in all other options. So the very important clue to this particular question is intravenous drug abuse and as well as the respiratory rate being 8 per minute. So these are the 2 points to tell that the individual is having a narcotic overdose. Right? So very simple. You need to take up the key point in the question, then you need to hit the answer. Similar way, we'll try to crack one more question. So we have a 72-year-old woman. She has been complaining of low-grade fever and dyspnea for 2 weeks. She has 10-year history of the scleroderma with the involvement of digits and the esophagus. She has a 30-pack year history of the cigarette smoking but quit 8 years ago. On chest radiograph, she has a nodular infiltrates in the right lower lobe. PET or CT shows the right lower lobe lesion. It is around 3 centimeters in diameter with nodular infiltrates characteristics and enhanced fluorodeoxyglucose uptake. Which of the following statements about Mrs. Wittstein is most accurate? The options are: the additional diagnostic studies are indicated. The findings on PET or CT makes the infection very likely. The findings on PET or CT make the infection very unlikely. The findings on PET or CT makes the malignancy very likely. The findings on PET or CT make malignancy very unlikely. Right? Now, so here the two important points. One is the patient is having the scleroderma. The patient is having the smoking history. So the patients who are having scleroderma, they will be having the esophageal dysmotility, and this esophageal dysmotility is the one which can make the individual to have GERD and as well as the aspiration. That point is there in patients with the scleroderma, right? And the patient is a smoker, right? Because the individual is having the history of smoking, there is a greater chance that the individual is at risk of development of the tumor, and that can be made out by this 3 centimeters in diameter with nodular infiltrates characteristic and enhanced fluorodeoxyglucose uptake. Okay, now what do you think it is? Is it the infection or is it the malignancy? So the patient is at risk of both, that is infection and as well as the malignancy. Right? And the findings on PET are consistent with either of the diagnosis. It can diagnose infection, it can diagnose the malignancy as well. Now, because the patient is having scleroderma induced esophageal dysfunction, there is a chance of the aspiration pneumonia. Because the patient is also having history of low grade fever, right? That can be attributed to the aspiration pneumonia. And most of the aspirations, they involve right lower lobe and particularly the superior segment. And if you see here, the right lower lobe lesion of 3 centimeters. Okay, so aspiration pneumonias mostly they involve the right lower lobe, right? And these aspiration pneumonia, they may appear as consolidation or the nodular infiltrates. That is regarding the aspiration pneumonia. And given the history of smoking, the individual is also at risk of the primary lung malignancy, right? And if you take this, the FDG PET scan, this will often differentiate benign from malignant lesions. Okay, so this has the capability of differentiating whether it is a benign lesion or a malignant lesion of 1 centimeter in diameter. However, with the FDG PET scan also, there can be, right, with FDG PET scan also, there can be false positive results, and with FDG PET scan, there can also be false negative finding. False positive results, they are seen in the inflammatory conditions, right? They are seen in the inflammatory conditions. False positive results are seen in the inflammatory conditions. Now, what are these inflammatory conditions such as pneumonia or granulomatous disease? Then, false negative findings, they occur in lesions with low metabolic activity, right? So what are these lesions with low metabolic activity? The lesions with low metabolic activity, that includes the carcinoid tumors, right? That includes the carcinoid tumors, and the other one is bronchoalveolar cell carcinoma, right? Bronchoalveolar cell carcinoma. So false positive and false negative findings can be there. So that is the reason why these patients, they will be requiring the additional diagnostic studies. What is that additional diagnostic studies? The additional diagnostic studies will be, you need to do a fiber optic bronchoscopy and you need to take the biopsy of that particular lesion, and then you need to evaluate that particular lesion, whether it is a malignant lesion or whether it is an inflammatory or infective lesion. So additional diagnostic studies are indicated. The only point which telling you why the additional diagnostic studies are required is false positive results are seen in inflammatory conditions such as pneumonia or granulomatous disease of the FDG PET scan. False negative results can occur in lesions with low metabolic activity such as carcinoid tumor and bronchoalveolar cell carcinoma. All right. So the answer is additional diagnostic studies are very much indicated in this patient. All right. Next question. So we have a 38-year-old woman. She is brought to the emergency department for status asthmaticus. She rapidly deteriorates and dies of her disease. All of the following pathological findings would likely be seen in this individual, except the options are infiltration of the airway with eosinophils and activated T lymphocytes, infiltration of the alveolar spaces with eosinophils and the neutrophils, occlusion of the airway lumen by the mucus plugs, thickening and edema of the airway wall, thickening of the basement membrane of the airways with subepithelial collagen deposition. Right. Now the question asked is incorrect statement. In patients with the asthma, the airway mucus is being affected, but not the alveolar spaces. Infiltration into the intra-alveolar space will not be there. Okay. So the pathology of asthma has largely been determined by examining bronchial biopsies of the patients with asthma as well as lungs. So you need to take the biopsy of the bronchi, that is the lung parenchyma, who is dying from asthma. Now, what is that you will find in the biopsy is the pathological changes are centered around the airways, right? The abnormalities present around the airways with sparing of the alveolar spaces. So in the alveolar spaces, you will not have the inflammatory cells, whereas in the airway, it is infiltrated by eosinophil, activated T lymphocytes and activated mucosal mast cell, right? The degree of inflammation does not correlate with the severity of the asthma. That is a very important point. And another common finding in all the asthmatics and individuals with eosinophilic bronchitis is thickening of the basement membrane. So thickening of the basement membrane is due to collagen deposition in the subepithelium. And what will happen to the smooth muscle? The airway smooth muscle is hypertrophied as well. right? And overall, this leads to thickening of the airway wall, which may also exhibit the edematous fluid, okay, which may also exhibit the presence of the edematous fluid, particularly in those with the fatal asthma. And in cases of fatal asthma, it is also common to find multiple airways are occluded by the mucus plugs. And what could be the reason for the death in these individuals? That is the occlusion of the airway lumen by the mucus plug. That might be the reason for the death of the individual. Okay, so the answer is the infiltration of the alveolar spaces with eosinophils and neutrophils will not be there in any patient with asthma. The inflammation is confined only to the airway wall, right? Next question. We have a 24-year-old woman. She was diagnosed with asthma 4 months ago and she was treated with inhaled albuterol as needed. Since her last visit, she feels generally well and typically requires using her inhaler approximately 4 to 7 times a week when around pollen or cats or when exercising in the cold air. So the requirement of the inhaler is almost 4 to 7 times a week. The inhaled albuterol generally helps and she only requires a repeat round of inhalation approximately 2 times a week. She is on no other medications and she is a non-smoker and her only pet is the goldfish named Puffer. Based on this information, you advise which of the following. First option, you need to add beclomethasone. You need to add the inhaled salmeterol twice daily. You need to add the inhaled thiotropium bromide. Continue the present therapy. So now if you see what are the main drugs for asthma, like we have bronchodilators and we have the anti-inflammatory drugs, right? And the bronchodilators are the one which will cause the relaxation of the airway smooth muscle, right? And they are the bronchodilators are the one which will help in the rapid relief of the symptoms, right? And the next important group of drugs are the anti-inflammatory drugs, right? So these anti-inflammatory drugs, right? These anti-inflammatory drugs, they are used as controllers, right? They are used as the controllers which inhibit the underlying inflammatory process, right? Which inhibit the underlying inflammatory process. Okay, now the answer in this particular question is you need to add the inhaled beclomethasone. I will tell you why. See, for patients who are having mild intermittent asthma, in them just only short acting beta agonist is all that is required, right? So use of reliever medication more than twice a week indicates the need for controller therapy. What is the reliever medication? Your bronchodilators are the reliever medications, whereas the corticosteroids are the controller medications, right? So the point here you need to understand is the individual, if he is requiring the reliever medications more than twice a week, that is an indication that he requires the controller therapy as well. So this patient is using her, right? This patient is using her reliever medications frequently. Therefore, a controller should be added to her regimen, right? And the treatment of choice for all patients as a controller therapy will be the inhaled corticosteroid given twice daily, right? And it is very much usual to start with an intermediate dose. Whenever you are starting this beclomethasone, you need to start 200 micrograms twice daily, right? 200 micrograms twice daily, right? Or equivalent dose you need to start, right? And then once the symptoms are controlled, you need to step down the beclomethasone. And if the symptoms are not controlled, in spite of adding this beclomethasone, if the symptoms are not controlled, then you need to add this long-acting beta agonist, right? When the patient is on short-acting beta agonist, if the symptoms are frequent, you need to add steroids. In spite of adding steroids, if the symptoms are not controlled, then you need to add the long-acting beta agonist, right? Which is most conveniently given by switching to a combination inhaler, right? So you need to give a combination of the steroid and as well as the long-acting beta agonist. and the dose of the controller should be adjusted accordingly as judged by the need for rescue inhaler. And next is this thiotropium bromide. Thiotropium bromide is a muscarinic receptor antagonist, okay, and they prevent only cholinergic nerve induced bronchoconstriction. Only cholinergic nerve induced bronchoconstriction is the only one that can be prevented by the muscarinic receptor antagonist. Okay, right? And these muscarinic receptor antagonists, they will also inhibit the mucus secretion, right? They will also inhibit the mucus secretion. Okay, so they can prevent, the ipratropium bromide can prevent, we have two drugs, ipratropium bromide and thiotropium bromide. They can prevent cholinergic nerve induced bronchoconstriction and mucus secretion as well, right? But this ipratropium bromide and thiotropium bromide, they are less effective than compared to that of your beta 2 agonist, that is the albuterol, right? They are less effective than beta 2 agonist in asthma therapy because they inhibit only the cholinergic reflex component of the bronchoconstriction, whereas beta 2 agonist will prevent all the bronchoconstrictor mechanisms. Salbutamol and salmeterol will inhibit all or will prevent all bronchoconstrictor mechanisms, whereas your ipratropium bromide will prevent only cholinergic nerve induced bronchoconstriction and as well as the mucus secretion, right? And these anticholinergic drugs, that is thiotropium bromide, may be used as an additional bronchodilator in patients with asthma. Okay, so when the patient is already on corticosteroid, when the patient is already on long-acting beta agonist, then this ipratropium bromide and thiotropium bromide may be used as the additional bronchodilators. Okay, we don't give this thiotropium bromide as the main bronchodilator. Okay, and the next one is the other important bronchodilator. It's a phosphodiesterase inhibitor, that is theophylline. Low doses of theophylline or an anti-leukotriene may also be considered as an add-on therapy, right? And these are less effective than LABA. So theophylline is the phosphodiesterase inhibitor, right? They are given only as an add-on therapy. If you take the efficacy wise, LABA has more efficacy than compared to that of the theophylline, right? And if asthma is not controlled despite the maximum recommended dose of the inhaled therapy, it is important to check the compliance and as well as the inhaler technique. You are giving maximum doses, but still the symptoms are not controlling, means you need to check the compliance and you need to check the technique of the inhalation, what the individual is using the inhaler. And in these patients, maintenance treatment with oral corticosteroids may be needed, and the lowest dose that maintains the control should be used. So if the technique is good, if the compliance is good, then you are giving maximum dose of the inhalation therapy, then the individual is still having symptoms, then the oral corticosteroid may be needed. Okay, so this is about the treatment of the asthma. Okay, so we have this stepwise approach. In mild intermittent asthma, right, only just short acting beta 2 agonist, whereas mild persistent asthma, along with SABA, inhaled corticosteroid low dose. Moderate persistent, you also need to add LABA as well. And in severe persistent, you need to step up the dose of inhaled corticosteroid. And in very severe persistent, you also need to add the oral corticosteroids as well. All right, next question. So we have a 28-year-old woman with long-standing mild persistent asthma comes to see you because she just found out that she is pregnant. She just found out that she is pregnant. Her only medications are the inhaled beclomethasone twice a day and albuterol as needed. She typically uses her albuterol less than twice per week. She wants to know what to expect regarding her asthma severity and whether any medication changes should be made at this time. Which of the following statements is correct? So the options are: she should continue her current therapy and follow the symptoms. She should switch from inhaled albuterol as needed to the inhaled thiotropium as needed. Then she should switch from the inhaled beclomethasone to inhaled salmeterol. There is greater than 70% chance that her asthma symptoms will become less severe during the pregnancy. There is greater than 70% chance that her asthma symptoms will become more severe during the pregnancy, right? So what has been found is approximately 1/3 of the asthmatic patients who are pregnant will improve during the course of pregnancy. right? 1/3 of asthmatic patients who are pregnant will improve during the course of pregnancy, right? Whereas 1/3 of patients, it has been found that they deteriorate during the pregnancy. And in 1/3 of patients, there is no change at all, right? There is no change in the severity of the symptoms, right? So it is important to maintain the good control of asthma, because poor control may have the adverse effects on the fetal development. Okay, so compliance may be a problem, because there is often a concern about the effect of asthma medications on the fetal development. But the point is, the drugs that have been used for many years in asthma therapy have now been shown to be completely safe without teratogenic potential. So that is the reason why she should continue her current therapy and follow the symptoms. So what are the safe drugs that can be given in the in pregnancy in asthma? Short-acting beta agonists like albuterol, inhaled corticosteroids like beclomethasone, phosphodiesterase inhibitors, that is theophylline, right? So these are the drugs which are completely safe, okay? But the less safety information is about the newer classes. So if you take the less safety information about the newer classes, such as LABA, that is long-acting beta agonist, that is salmeterol, then anti-leukotrienes, right? Anti-leukotrienes, and as well as anti-immunoglobulins, right? Anti-immunoglobulins. These are the newer molecules. These are having a less safety information in pregnancy, right? And if at all, if the patient is requiring oral steroid, what is the oral steroid, right? What is the oral steroid that is needed? So the oral steroid that is needed is, it is better to use the prednisone, right? It is better to use the prednisone than prednisolone, right? It is better to use prednisone than prednisolone, because it cannot be converted to the active prednisolone by the fetal liver. So thereby, this prednisone has protecting effect on the fetus, whereas the prednisolone, it can cause certain teratogenicity, right? But prednisone is safe. And very important is, when the individual is taking the oral corticosteroid, there is no contraindication for the breastfeeding, right? There is no contraindication to breastfeeding when patients are using these particular drugs. So that is the reason why she should continue her current therapy and follow the symptoms. Because what is she taking? She is taking beclomethasone, right, which is completely safe. And the other drugs, yeah, she's taking albuterol, even that is also completely safe, right? So moving on to the next question, right? Chronic silicosis is related to an increased risk of which of the following conditions? Infection with invasive aspergillosis, infection with Mycobacterium tuberculosis, lung cancer, rheumatoid arthritis, and all of the above. So silicosis is associated with all of these. Okay, what exactly is silicosis? Silicosis results from the inhalation of the free silica, which is nothing but the crystalline quartz. And this silicosis is associated with mining, stone cutting, foundry work, and as well as the quarrying. And the chronic form of silicosis has been associated with increased risk of variety of diseases, right? The chronic form of silicosis has been associated with increased risk of variety of diseases. And this particular silica, it is known to be cytotoxic, right? It is known to be cytotoxic to the alveolar macrophages, right? Cytotoxic to the alveolar macrophages, right? So patients are at increased risk of the pulmonary infections. Certain pulmonary infections, they are completely dependent on the macrophages for giving the immunity. Now when silica is cytotoxic to these alveolar macrophages, the infections which are depending on the cellular immunity are cut down, and these individuals, they are at increased risk of Mycobacterium tuberculosis. These infections, these individuals, they are at increased risk of the infections with the atypical mycobacteria, and they are also at increased risk of infections with the fungus, that is aspergillus. Okay, and in addition, silicosis is associated with the development of the connective tissue disorders. What are these connective tissue disorders? That is rheumatoid arthritis. Okay, so rheumatoid arthritis with rheumatoid nodules. So the silicosis is associated with the Kaplan syndrome, where there will be rheumatoid nodules and as well as the rheumatoid arthritis, and they are also at increased risk of the scleroderma as well, right? And please remember, the silica is listed as probable lung carcinogen. That is the reason why these individuals are at increased risk of malignancy as well. Okay, so the answer is all of these are associated with the chronic silicosis. Next question. All of the following occupational lung disease are correctly matched with the exposure except berylliosis, high technology electronics; byssinosis, cotton mining; farmer's lung, moldy hay; progressive massive fibrosis observed in shipyard workers; metal fume fever in welding. So the incorrect statement is the progressive massive fibrosis seen in shipyard workers is the incorrect statement. So basically all these are the occupational lung diseases, right? So these occupational lung diseases have been associated with wide variety of organic and inorganic exposure in the workplace, right? And clinically they can range from the primary airway disease to the progressive pulmonary fibrosis. This will be the range of these occupational lung diseases, right? Primary airway disease to the progressive pulmonary fibrosis. And when you are evaluating a patient for new pulmonary diagnosis, it is important to perform a detailed occupational history to determine if there is possibility that the patient profession may be causing this particular pulmonary pathology, right? So if you take the specific clinical findings, what are the inorganic dust? The inorganic dust include asbestosis, they include the silica, they include the coal dust, they include beryllium and variety of other metals. These are all the inorganic dust. Okay, now out of which the asbestosis and as well as the silica, they are the most common exposures. Asbestosis and as well as the silica are among the most common exposures. And this particular asbestosis, right, it is associated with mining, it is associated with construction, it is associated with the ship repair. And in areas near where asbestos mining has occurred, the general population also has shown an increased risk of asbestos related lung disease. And clinically, asbestos exposure is associated with a range of clinical syndromes that includes the asbestosis, which is nothing but the interstitial lung disease, right? And there can be the pleural plaques, and there can be the pleural effusion, and there can be lung cancer, right? And there can also be development of the mesothelioma. So these are all the problems associated with the asbestosis, right? And you take this silica exposure. Silica exposure is common among the miners, right? And these silica exposure, it is common among the miners, stonemasons, and individuals involved in sandblasting or quarrying. So silica exposure is common among these certain group of individuals, and a variety of syndromes can occur with silica exposure, right? Just now as I have discussed, the silica exposure, it is associated with, so it is the silica exposure which is associated with the progressive massive fibrosis. It is not shipyard workers. Shipyard workers, it is asbestosis. Okay, so a variety of clinical syndrome that can occur with silica exposure is progressive massive fibrosis, where the upper lobe consolidated nodules will be there of more than 1 centimeter in case of silicosis. And coal mining is also associated with a clinical picture similar to that of the silicosis. Next is the beryllium. Beryllium is a lightweight metal that is highly conductive, and it is used in the high-tech industries, right? And the classic disease associated with beryllium exposure is chronic granulomatous disease, right? Which is the clinical appearance to sarcoidosis. Okay, so beryllium is associated with chronic granulomatous disease. Okay, and the other metals that can produce the clinical syndromes are welders of galvanized metal, right? Welders of galvanized metal who use zinc oxide, right? Who use the zinc oxide, they are susceptible for metal fume fever. They are susceptible for metal fume fever, right? So these are all, the inorganic dust. Whereas if you take the organic dust that can lead to the occupational lung disease include the cotton dust, the grain dust, then toxic chemicals, and the agriculture dust. These are some of the organic dust, and out of which you take the cotton milling. So this particular cotton milling, right, and cotton milling and processing, they can present with clinical syndrome known as the bicyanosis, okay, which has asthma-like features, right, which has asthma-like features. And many of the organic dust exposures also lead to hypersensitivity pneumonitis as well, right? So this particular hypersensitivity pneumonitis syndrome, that is related to the occupational exposures, which include the farmer's lung, right? And the hypersensitivity pneumonitis can also be secondary to the pigeon breeder's lung. It can also be secondary to malt worker's lung, right? So in farmer's lung, the most common cause is the moldy hay. What is there in this moldy hay? It is thermophilic actinomyces species, right? So thermophilic actinomyces species, which is there in the farmer's lung, that is what is responsible for the hypersensitivity pneumonitis, right? And the other examples of hypersensitivity pneumonitis is the pigeon breeder's lung and as well as the malt worker's lung. So the incorrect statement is the progressive massive fibrosis is not associated with the shipyard workers, it is associated with the silica exposure, and this shipyard workers, they are associated with this asbestosis. Okay, next question. We have a 53-year-old man is seen in the emergency department with sudden onset fever, chills, malaise and shortness of breath, but there is no wheezing. He has no significant past medical history and is a farmer. Of note, he worked earlier in days taking hay, and postero-anterior and lateral chest radiograph shows diffuse bilateral alveolar infiltrates. Which organism is most likely to be responsible for this presentation? Nocardia, then histoplasma, cryptococcus, actinomyces, and then the aspergillus fumigatus. So now with the clinical history given, the answer is the actinomyces species. So the patient is presenting with the acute onset, right? Patient is presenting with the acute onset pulmonary symptoms, and these acute onset pulmonary symptoms include wheezing, right? And there is also dyspnea. So he is a farmer and was recently handling the hay, right? And was recently handling the hay, right? And the clinical presentation and radiogram are consistent with the farmer's lung, right? The clinical presentation and radiogram, they are consistent with the farmer's lung, which is a hypersensitivity pneumonitis which is caused by the actinomyces. And in this disorder, the moldy hay, right? In this disorder, the moldy hay with spores of actinomyces are inhaled and produced the hypersensitivity pneumonitis. And the disorder is seen most commonly in rainy periods when spores multiply. And these patients, they present with 4 to 8 hours after exposure with fever. So generally 4 to 8 hours after the exposure, they present with fever, cough, shortness of breath without wheezing. And the chest radiogram often show a patchy, bilateral, often upper lobe infiltrates will be there in case of this actinomyces. Okay, patchy, bilateral, often upper lobe infiltrates. And the exposure history will differentiate this disorder from other types of the pneumonia. So because the individual is having the history of exposure to the hay, the answer is the actinomyces species, right? Next question. A 36-year-old woman, she is brought into the intensive care after the house fire. She is uptended but did not suffer any major burns. She is being treated for the smoke inhalation. Her initial carboxyhemoglobin concentration is around 25% and she is treated with 100% oxygen but remains uptended. She subsequently develops generalized seizures. Her blood pressure rapidly declines to 60/40. The heart rate is around 150 beats per minute. Saturation is 98%. There is ruddy appearance to the patient's complexion and a bitter almond odor is present. There is soot around the patient's nose and as well as mouth. The pupils are dilated and the skin is diaphoretic. Which of the following tests will yield the diagnosis? Ammonia concentration, blood lactate levels, carboxyhemoglobin level, red blood cell cyanide concentration, methemoglobin levels. Okay, so with the clinical scenario which has been given, the answer is red blood cell cyanide concentration. Why? I'll discuss. See, firefighters and fire victims, they are at risk of smoke inhalation injury which is an important cause of acute cardiorespiratory failure, right? Which is an important cause of acute cardiorespiratory failure. In addition to the risk of these patients who are like the victims of the fire, they are at risk of carbon monoxide poisoning. And these individuals are also at risk of toxic inhalation injury from the fumes which are released from the burning of the synthetic material, right? And this patient has the carbon monoxide level that requires the treatment with 100% oxygen, because the carboxyhemoglobin level, if you take, okay, so it is around 25%, definitely he requires the 100% oxygen, right? But he would not be expected to lead to a significant cardiorespiratory collapse. And recently, cyanide toxicity has been recognized as a significant cause of morbidity and mortality following this particular fire exposure. And this cyanide toxicity can present with rapid development of the neurogenic and the cardiorespiratory collapse, right? So what will be the neurological symptoms? The neurological symptoms include mild headache to confusion. There can be development of seizures, and there can also be development of the coma, right? And the cardiovascular collapse, the hypotension. So hypotension with significant lactic acidosis is prominent, right? So often an elevated lactate level leads to suspicion of the concomitant cyanide toxicity. So the point here is the lactate hypotension with significant lactic acidosis is present. So often an elevated lactate levels lead to suspicion of concomitant cyanide toxicity in an individual with smoke inhalation injury. However, the definitive method by which you can diagnose the cyanide toxicity is not by the blood lactate levels. The definitive method by which you can make out the cyanide toxicity will be red blood cell cyanide concentration, right? Red blood cell cyanide concentration. So the answer is D here. So this patient is having cyanide toxicity. Okay. Next question. An infant is diagnosed with cystic fibrosis when a sweat chloride returns positive at 110 millimoles per liter after an abnormal newborn screening test. The drug ivacaftor, recently approved by FDA, is indicated in patients with which of the following genetic mutations? G542X, G551D, F508 deletion, 621 plus 1GT mutation, R117C mutation, right? So this particular ivacaftor, it is the one which will prevent the progression of the cystic fibrosis, right? So it is an inherited disorder. Cystic fibrosis is an inherited disorder, and the protein that is being defective is CFTR, that is cystic fibrosis transmembrane regulator protein. It's a large ion channel which is present in the cell membrane, which is responsible for the chloride ion transport that is being defective, right? That is being defective in this particular individual. Okay, so this CFTR, if it is absent, the individuals with cystic fibrosis have a variety of disease manifestations related to impaired exocrine function. Now, what are the primary disease manifestations secondary to this cystic fibrosis? So, in cystic fibrosis, you have respiratory abnormality, pancreatic abnormality, respiratory abnormality in the form of chronic sino-pulmonary infection, and impaired exocrine pancreatic function, and there is also poor nutrition as well. Now, if you take the gene that encodes CFTR, where is the gene that encodes CFTR? It is present on chromosome 7, right? It is present on chromosome 7, and more than 2000 mutations have been described. More than 2000 mutations have been described. Okay, so the mutations, if you see, you have class 1 mutation, class 2 mutation, class 3, class 4 and class 5 mutations, right? Mainly up to class 4. Okay, now if you take these mutations, you take class 1 mutation, that is G542X 621 plus 1 GT mutation, that will lead to the absence of synthesis, most frequently through the presence of abnormal stop codon. That is class 1 mutation of the impairment of CFTR function. Then class 2 mutation, there is F508 deletion. And the class 3 mutation, it is G551D mutation. And type 4 mutation R117H, R117C, that is being mutated. And in type 5, they are splice mutations. out of which you take this ivacaftor. This particular ivacaftor, it is associated with, right, this ivacaftor, it is associated with the improvement in the gene mutation of G551D. That is the answer in this question. So these are the important questions in the respiratory system and critical care. And thank you very much for watching this particular session. And I will see you in the next session again. Thank you very much.